Let's talk about glaucoma. When we say glaucoma, we're talking about a group of eye diseases where the pressure inside the eye, what we call intraocular pressure, or IOP, becomes too high for the optic nerve to handle. Over time, that pressure can damage the optic nerve and its fibers, and once that damage is done, it's permanent. The tricky part is that you don't have to have very high pressures to lose vision. Some people can have normal pressures and still lose nerve fibers, while others tolerate higher pressures for years without a problem. That's why glaucoma can be sneaky. It's sometimes called the silent thief of sight. Physiology refresher. Aqueous humor, the clear fluid that nourishes the cornea and lens, flows from behind the iris, between the iris and the lens, into the front chamber of the eye. About 90% drains through the trabecular meshwork, into the canal of Schlemm, and then into the veins. The remaining 10% drains through the ciliary body into deeper tissues before joining the venous system. For proper drainage, the angle between the cornea and iris should be about 45 degrees. If that angle narrows, the iris can block the meshwork and slow outflow. Fluid production also tends to decrease with age, diabetes, and inflammation, which can further upset the balance. Who's at risk? Glaucoma risk is higher for Black or Asian patients, those with a family history, cardiovascular disease, diabetes, migraines, myopia, older age, sleep apnea, prior eye injury, long-term steroid use, or thin corneas. How damage happens. Two main theories explain optic nerve damage in glaucoma. Mechanical. High pressure physically damages the nerve fibers. Ischemic. Pressure compresses tiny blood vessels, cutting off oxygen to nerve cells. Most cases involve both mechanisms. Types of glaucoma. Glaucoma can be primary, no other cause, or secondary from trauma, steroid use, or other eye conditions. Open-angle glaucoma. The drainage angle looks normal, but fluid can't escape fast enough. Usually affects both eyes, but may be worse in one. Normal tension glaucoma. Damage occurs at IOP 21 mm/Hg. Ocular hypertension. IOP is elevated, but the optic nerve is still healthy. Angle closure glaucoma. The iris blocks the drainage meshwork. Acute angle closure, a medical emergency, sudden severe eye pain, blurry vision, halos, nausea, and a red cloudy eye with a mid-dilated pupil. Needs immediate medication to lower IOP and laser surgery. Subacute or chronic, less dramatic but still damaging over time. What patients notice? Most patients don't notice glaucoma until significant vision is gone, usually starting with peripheral vision loss. They may later develop halos, trouble focusing, or difficulty adjusting to low light. Acute angle closure is the exception. It's painful and obvious right away. Diagnosing glaucoma. A workup includes detailed history for risk factors and symptoms, tonometry to measure IOP, ophthalmoscopy to look for optic nerve pallor and cupping, visual field testing to map blind spots with patterns unique to glaucoma. Medical management goal. Keep IOP low enough to prevent further damage, usually 30% below baseline. Treatment can involve medications, laser therapy, surgery, or a combination. Common medications, miotics, pilocarpine, constrict the pupil to improve drainage, may cause brow ache and poor night vision. Beta blockers, timolol, reduce fluid production, avoid in asthma, COPD, and certain heart conditions. Alpha adrenergic agonists, bromonidine, reduce production, may cause redness and dry mouth. Carbonic anhydrase inhibitors, dorzolamide, acetazolamide, reduce production. Oral forms have more systemic side effects and sulfa allergy concerns. Prostaglandin analogs, latanoprost, increase outflow, can darken the iris. Surgical options, laser trabeculoplasty, improves outflow. Laser iridotomy, opens the iris in angle closure glaucoma. Trabeculectomy, creates a new drainage path. Drainage implants shunts, used when other surgeries fail. Nursing management, teach disease basics, target IOP, and the importance of sticking to medication routines. Demonstrate correct drop technique, including punctal occlusion to reduce systemic absorption. Prepare patients for possible side effects so they aren't surprised. Monitor for adherence, cost concerns, and dosing challenges. Arrange low vision services or mobility training for advanced cases. Patient self-care essentials. Know your IOP and target range. Keep records of pressures and visual field tests. Review medications with the ophthalmologist. Use drops exactly as prescribed. Keep every follow-up appointment. Key takeaway. Glaucoma can be controlled but not cured. Catch it early, treat it consistently, and support patients to protect the vision they still have. Every drop, every visit, and every conversation counts.